is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 5 of our new series entitled Instability Syndromes and the AMA Guides. In sessions 1 through 4 of this program, we spent a great deal of time talking about the instability syndromes of the upper extremity. So session 1 was about shoulder instability. Session number 2 was about instabilities of the elbow. And then sessions 3 and 4 were all about 2 types of instability syndromes at the wrist. Session 1 was about what the AMA guys referred to as dissociative carpal instability. And then session 4, or session 2, depending on how you look at it, was all about the non-dissociative forms of carpal instability. So that fully handled the upper extremity. In today's discussion, I want to get into the lower extremity and talk to you about instability syndromes that follow knee injuries. So this has to do with your knee injury cases. Now, with knee injury cases, part of your physical evaluation of injured workers in the permanent impairment evaluation is to assess the examinee for impairment due to ligamentous instability of the knee. And it's interesting because you will find these instability syndromes if you simply examine for them. Now, the primary instability syndromes of the knee are going to involve the 4 major ligaments that circumferentially surround the knee. So we have the medial collateral ligament, posterior cruciate ligament, lateral collateral ligament, and the anterior cruciate ligament. Well, surprise, surprise, is that rarely, meaning that it's the exceptional case that involves injury to an isolated or singular ligamentous structure. More commonly, more the rule than the exception, is multiple ligamentous injury in the same examinee from the same injury. And this has to do with the mechanism of injury involving a variety and multitudinous vectors of forces and vectors of injury, typically involving some combination of varus or valgus and internal or external or flexion and extension forces and combined forces that conspire to result in what the literature refers to as compound or complex ligamentous injuries. So in today's discussion, I want to review with you these compound and complex ligamentous injuries of the knee. I want to review the physical examination maneuvers that will help elucidate and confirm these compound and complex ligamentous injuries. And then we'll talk a bit about what the AMA Guides has to say in terms of the permanent impairment ratings for these examinees. So with no further ado, let's get right into today's discussion regarding the knee instability syndromes. Okay, so let's begin. We're in chapter 17 and we're talking about instability syndromes of the knee. So to begin, let's talk about the different types of impairments that the AMA guides inform us that we must assess for in the evaluation of our examinee. Well, the AMA guides in table 17.1 describe 3 broad classifications or categories of lower extremity impairments. There's the anatomic impairments, there's the functional impairments, and there's the diagnosis-based impairments. And the diagnosis-based impairments are all found in table 1733 of the AMA guides. And it's here in this table that they talk about ligament injuries. So when you do your physical examination of your examinee, you must assess for the presence or absence of ligamentous instabilities in your examinee. See, the AMA guides require that when we have a lower extremity case, that we assess the examinee for every single one of these impairments, every single one of the anatomic impairments, every single one of the functional impairments, and every single one of the diagnosis-based impairments. And if the examinee does not have any of these impairments, that's fine, but many times qualified medical evaluators are missing impairments that the examinee truly has and truly qualifies for because they don't do a permanent impairment evaluation. They do a physical examination more consistent with what they would do in their clinical practice, which has as its function to assess or to determine a diagnosis. Well, in our qualified medical evaluation practice, we're not examining to determine a diagnosis. Many times by the time we see the examinee, he's already been well diagnosed by many practitioners. Our role is to assess the examinee for the presence or the absence of impairments. And the AMA guides tell us that ligament injuries do result in impairments, which we must assess for. And we'll talk about how to assess the knee ligaments in today's discussion. Well, in examinees who truly do have sequelae from ligament injuries and do truly have instability or laxity syndromes of the knee ligaments, Table 1733 provides anywhere from 3 to 15% whole person impairment for the effects that those instability syndromes have on the examinee's activities of daily living. So the first category of impairments that the AMA guides provide for is for laxity of either the anterior or posterior cruciate ligaments or the medial or lateral collateral ligaments. So here they provide for impairment for either a cruciate or a collateral ligament injury, and they describe the three classifications of ligament injury as mild, moderate, or severe. Now, the AMA guides don't define mild laxity. They don't define moderate laxity. They don't define severe laxity. So we'll talk about some parameters that you can rely upon in the assessment of your examinee. And then the next category of impairment that the AMA guides provide for is a combined injury, where we have a cruciate and a collateral ligament injury. And here they provide for moderate and severe laxities with quite generous permanent impairment ratings of 10 and 15%. Well, one of the philosophies of today's discussions and one of the principles I want you to take with you into your very next physical examination with your examinee is that many times these knee ligamentous injuries do not occur. They rarely occur in isolation. So it's the rare incident when we see simply a single injury, single and isolated injury to, say, for example, the medial collateral ligament, or an isolated injury to the anterior cruciate ligament. Much more commonly is that we have a combined injury where we have injury to both a cruciate and a collateral ligament injury. And that has to do with the mechanism of injury in these knee ligament injury cases. Many times the mechanism of injury involves a varus or valgus stress combined with some form of a rotational and some form of a flexion stress. So because there's multiple vectors contributing to the injury, multiple ligamentous structures can suffer damage. And so it's more common than not that your examinee will qualify for the higher levels of permanent impairment rating due to combined injury to both the cruciate and the collateral ligaments. And we'll talk about how to detect these combined injuries as we continue on today. Now, because the AMA guides basically provide no discussion about ligamentous instability syndromes of the knee, I provided for us an outside reference, which has become a classic paper published in the British Journal of the British Journal of Sports Medicine in 2000, and I'll be referring to this report throughout today's discussion.
So in order to provide us some background in the anatomy and pathoanatomy and physical examination of the knee, we're going to be relying upon this as our baseline reference. So according to this report, which gives us some in-depth discussion of the ligamentous structures of the knee, the stability of the knee is maintained by several structures. It's maintained by osseous structures, it's maintained by ligamentous and capsular structures, and then it's also maintained by muscular structures. So with regards to the osseous restraints, it's the shape of the condyles, both the medial and lateral femoral condyles and the medial and lateral tibial condyles, also known as the tibial plateaus, that provides some measure of stability to the knee. Now, because of the shape of the tibial plateaus or the tibial condyles basically being flat and planar surfaces, the osseous restraints of the knee are not strong, are not stable. They're not like the elbow where we have a deep interosseous cavity that provides circumferential restraint around the bony structures. Rather, in the knee, we have a paucity of osseous restraints, and so the bulk of the restraint is provided for by the passive and the dynamic structures. Now, in today's discussion, we're going to talk about the medial collateral ligament, the lateral collateral ligament, anterior cruciate ligament, the posterior cruciate ligament. We'll talk about the posteromedial and posterolateral capsule, and then also on a superficial layer basis, the iliotibial tract provides some passive restraint to lateral forces, lateral varus forces of the knee. And I'll show you a good graphic that depicts exactly how the iliotibial tract contributes to knee stability. And then dynamically, the muscles that act over the joint, such as the quadriceps, such as the gastrocnemius, such as the hamstring, and then medially, such as the gracilis and the sartorius, tone of these muscles and dynamic contractions of these muscles also contribute to the stability of the knee. And therefore, of course, any pathology involving any of the tendons or any of the muscles themselves will compromise dynamic stability of the knee. Okay, so let's talk a little bit about each of these stabilizing structures. Okay, so let's begin with the medial collateral ligament. So here in this diagram, we have a posterior view here, and we have a medial view of the knee here. And the medial collateral ligament has as its origin the medial femoral condyle. So that area is depicted right here in this region here. And you'll notice that the medial collateral ligament is slightly posteriorly placed relative to the center of axis of rotation of the knee. The insertion of the medial femoral condyle is on the tibial metaphysis, approximately 4 to 5 centimeters distal to the medial joint line beneath the pes anserinus insertion. So here we have the superficial component of the medial collateral ligament, showing its origin here on the medial femoral condyle, and then traversing down to attach on the distal tibial metaphysis. So there is the superficial proximal and the superficial distal aspect of the medial collateral ligament. We'll talk about a deep component of the medial collateral ligament as well. Now, just posterior to the medial collateral ligament is another medial stabilizer of the knee. This is known as the posterior oblique ligament. That's labeled here as the POL. And the POL, like many other ligaments around the knee and around the shoulder and around the elbow, are simply capsular thickenings of the capsule, localized regions of the capsule that has an increased linear density of collagen fibers. And so the same is true of the posterior oblique ligament here, which is simply a thickening of the posterior medial capsule. Okay, so the posterior oblique ligament is going to provide some stability for to resist medial forces, medially directed forces, and also to resist posteromedial rotatory forces. Okay, so far we have the superficial medial collateral ligament, we have the posterior oblique ligament, and then if we were to peel away the superficial medial collateral ligament here, we would be left with the deep medial collateral ligament, deep to the superficial aspect of the medial collateral ligament. And this is an interesting ligament because it has attachment on the tibia, it has attachment on the femur, and then it has a central attachment on the medial meniscus. So the superior portion of the ligament is referred to as the meniscofemoral portion. The inferior portion is referred to as the meniscotibial portion. And this is important because injury to the deep component of the medial collateral ligament can also result in a concomitant or simultaneous injury to the medial meniscus. Now, this is unique to the medial collateral ligament. The lateral collateral ligament has no such attachment to the meniscus, but the medial collateral ligament is directly and firmly adherent to the medial meniscus through the deep component of the medial collateral ligament. So these these valgus directed injuries that result in injury to the medial collateral ligament, the posterior oblique ligament, many times also include a component of medial meniscus injury as well. So in that case, your physical examination would need to identify both the ligamentous laxity component of the impairment as well as the meniscal tearing aspect of the impairment. Okay? Okay, so in addition to the superficial and deep components of the medial collateral ligament and the posterior oblique ligament, we also have a medial capsular ligament. The medial capsular ligament is deep to the medial collateral ligament, and the combination of the posterior oblique ligament here and the medial capsular ligament underneath the deep aspect of the medial collateral ligament, these form what's referred to in the literature as the medial ligament complex. And the medial ligament complex, independent of the medial collateral ligament, provide resistance to valgus forces when the knee is in full extension, and these ligaments relax at approximately 20 to 30 degrees of flexion, wherein at that point, at 30 degrees of flexion, the medial collateral ligament becomes the primary restraint to resist valgus forces. So knowing that, it's going to become important that when we test or when we apply our provocative maneuvers to the knee, we test the knee both in full extension to assess the integrity of the medial ligament complex, as well as testing the knee in 30 degrees of flexion to assess the integrity of the superficial and deep aspects of the medial collateral ligament. And then in addition to these ligamentous structures resisting valgus forces, the combination of the medial collateral ligament, the posterior oblique ligament, and the medial capsular ligament, these together resist abnormal tibial internal rotation. And many of these injuries to the medial ligament complex and the medial collateral ligament involve a rotational component, as the examinee either rotates on a planted foot or has the tibia itself rotated upon a fixed femur. Now, isolated medial collateral ligament injury occurs when the examinee suffers a lateral blow to the knee with the knee slightly flexed. If the knee was in full extension, the injury, of course, would be greater to the posterior oblique ligament and also to the medial capsular ligament. So we're going to test the examinee in both positions. And when the deforming force includes a rotation component, as it many times does, injuries can include the entirety of the medial ligament complex, as well as injury to the cruciate ligaments, both the anterior and posterior cruciate ligaments can simultaneously occur. And this is one example where we're going to be able to provide for the higher impairment rating due to combined collateral and cruciate ligament injuries. So I'm going to point out these examples in these types of injuries that result in combined ligamentous injuries to the knee. So I'm sure you've seen in the literature references to the injury, the mechanism of injury referred to as the unhappy triad. And with the unhappy triad, we typically see a football player who's pivoting on a planted foot when he has a laterally directed force, a valgus force imposed upon the knee while the knee is slightly flexed and planted, and that results in injury to the entirety of the medial ligamentous complex, which then causes an injury to the medial meniscus because of the meniscofemoral and meniscotibial attachments of the deep medial collateral ligament, and then typically also involves injury to the anterior cruciate ligament. So in our knee injury cases, we need to assess and be forever attuned to the possibility that the examinee has more than one ligamentous structure involved with the impairment. Okay, so let's talk about the physical examination to assess for medial knee instabilities. Okay, so the physical examination, of course, always begins with inspection. And in the acute setting, you're going to find a localized bruise on the medial aspect of the knee with some swelling. And in the chronic setting, there may be some swelling and some visible hardening of the tissues, both the skin and the subcutaneous tissues on the medial aspect of the knee. And this hardening represents an ossification, a chronic ossification of the medial collateral ligament. This is known as a Pellegrini striata lesion, and I'll show you a radiographic depiction of that here in just a minute. To palpation, there'll be a localized tenderness to the medial knee, both above and below, and even at the joint line. And with provocative testing, we want to apply a valgus force both with the knee in full extension and then also again with the knee flexed in approximately 15 to 20 degrees of flexion. When we see a medial joint opening greater than 5 millimeters, that indicates substantial structural damage to the medial collateral ligament, at least when the knee is tested in flexion. On the other hand, excessive opening at full extension indicates a combined injury to the medial collateral ligament and also the medial ligament complex, consisting of the posterior oblique ligament and the medial capsular ligament, and should alert the examiner, which is you, to the strong possibility also of an associated anterior cruciate ligament or posterior cruciate ligament injury, which would represent a combined injury, which would qualify for a permanent impairment rating due to collateral and cruciate ligament damage. So thus the importance of testing the examinee in at least two positions for the medial collateral ligament. First in full extension, and then also in 15 to 20 degrees of knee joint flexion. In the chronic setting, chronic medial collateral ligament insufficiency by itself in isolation is rare. When it persists, it's usually due to a combined injury with an associated ACL or a PCL laxity simultaneously. This would then qualify the examinee for a combined impairment rating. Now, chronic insufficiency of the medial collateral ligament can occur both with and without posteromedial rotatory instability. When we have posteromedial rotatory instability, that's suggestive of permanent laxity and damage to the medial ligamentous complex consisting of the posterior oblique ligament and also the medial capsular ligament. When the medial collateral ligament insufficiency or laxity is in isolation without posteromedial rotatory instability, these generally are treated conservatively and generally respond well to conservative treatment measures. When there is a component of posteromedial rotatory instability, this suggests a more significant and extensive lesion, and orthopedically is generally treated with a surgical reconstruction of the posterior oblique ligament with a free hamstring tendon graft. So you will know this by review of the examinee's history. If they have had this surgical treatment due to combined injury of the entirety of the medial ligamentous complex and also of an associated either anterior or posterior cruciate ligament injury. And then also by physical examination and also by diagnostic studies is a telltale sign that will sharpen and quicken your thinking to the possibility that the examinee has medial collateral ligament insufficiency, which is known as the Pellegrini striata lesion. So here we have an example of a Pellegrini striata lesion, which is an ossification of the origin of the medial collateral ligament here on the medial femoral condyle. So the Pellegrini striata lesion shows up on knee radiographs to alert you that there indeed has been a prior history of medial collateral ligament injury. So according to the literature, the Pellegrini striata lesion is an ossified post-traumatic lesion at or near the medial femoral collateral ligament, also known as the medial collateral ligament, adjacent to the margin of the medial femoral condyle. One presumed mechanism of injury is a striata fracture, which is an avulsion injury of the medial collateral ligament at the medial femoral condyle here. That it represents an avulsion fracture of the medial femoral condyle, in which case calcification usually begins to form a few weeks after the initial injury. Now on physical examination, this area here will generally be tender and slightly swollen and hardened to palpation pressure. That may be your only indication to the possibility of this lesion, but this lesion will definitely show up on A to P radiographs of the knee. And this represents a positive radiographic examination finding for medial collateral ligament insufficiency when you find it. Now, when you find it and you consider this to be an avulsion fracture of the medial femoral condyle, that suggests a severe injury and it suggests a compound injury. So make sure to assess also for ligamentous instability of either or both of the anterior and the posterior cruciate ligaments. Okay, so that is the medial collateral ligament. Let's now talk about the lateral collateral ligament. Okay, so the lateral collateral ligament on the lateral aspect of the knee has as its origin now the lateral epicondyle of the femur, whereas the medial collateral ligament was attached to the medial epicondyle. And the insertion of the lateral collateral ligament is onto the head of the fibula. It's interesting. The lateral collateral ligament has no direct attachment to the tibia bone. Rather, it's attached on the head of the fibula. Now, isolated lateral collateral ligament injury is rare. It more generally occurs as part of an injury to what's referred to as the posterolateral corner. And the lateral collateral ligament forms one layer of 3 layers of the posterolateral corner. So injury to the lateral collateral ligament generally includes injury to one or more of the other components of the posterolateral corner, and may also involve injury to the anterior cruciate ligament and also the posterior cruciate ligament. So, like the medial collateral ligament, isolated injury to the lateral collateral ligament is rare, and so you must assess your examinee for combined injury to either the anterior or posterior cruciate ligaments, in which case the examinee would qualify for the highest impairment ratings for combined injury, which is provided for by the AMA guides. Now, with regards to the posterolateral corner, we can think of the lateral stabilization of the knee as occurring in 3 layers, with the superficial layer consisting of the fascia and connective tissue associated with the biceps femoris tendon, and the fascial tissue of the iliotibial tract, consisting of comprising the superficial layer, the lateral collateral ligament itself comprising the middle layer, and then the deepest layer is consisting of the posterolateral corner structures, including the popliteus tendon, the popliteofibular ligament, the arcuate ligament, and then also the posterolateral joint complex. So let's take a look at these structures. Okay, on the left here we have a depiction of the lateral collateral ligament, and it depicts the LCL here in isolation. Just remember that the lateral collateral ligament forms the second layer of 3 layers of lateral stabilizers of the knee. So here shows the lateral collateral ligament attaching or inserting or originating from the medial femoral condyle and attaching down to the head of the fibula here. And this particular diagram shows 3 grades of injury to the lateral collateral ligament: a grade 1, which is mild; grade 2, which is moderate and a complete rupture; grade 3, which is a severe injury to the lateral collateral ligament. Well, by the time injury gets into the lateral collateral ligament, many of the other structures of the lateral knee become involved, as depicted here on this diagram. So you can think of the lateral stabilization of the knee as being contributed to by 3 layers of structures. Most superficially, we have the connective tissue, the collagen tissue of the biceps tendon, and then also the iliotibial tract, which have been dissected away from their attachments here and across here, forming the most superficial support or restraint for lateral forces of the knee. Now, deep to the iliotibial tract and also the biceps femoris tendon, we have the lateral collateral ligament itself, which is depicted here. And you see how that's invested in the fascial tissue. So that extends from here. It's been dissected in this diagram right through here. And then here is its proximal portion to attach here on the lateral femoral epicondyle. So that's the intermediate layer of lateral support. And then we have the innermost structures comprising what's referred to as the posterolateral corner, which includes the popliteofibular ligament here, the structure here, which goes from the popliteus tendon to the head of the fibula here. So that's a popliteofibular ligament there. Then we have the popliteus muscle, which is depicted here. We have the inner aspect of the joint capsule, posterolateral joint capsule, depicted deep to the lateral collateral ligament. We have the arcuate ligament depicted here, providing restraint, especially posteriorly and posterior laterally in the posterior aspect of the knee. And then finally we have the popliteus tendon running from the popliteus muscle right through in this structure here. So this is the innermost stabilizers to lateral varus forces and posterolateral forces of the knee. With significant injury significant enough to impact the lateral collateral ligament, it's likely, if not probable, that there will also be injury to the posterolateral corner structures, and then also more superficial structures such as the iliotibial band and also the biceps femoris tendon. And this may cause you to think, what other types of impairments your examinee may qualify for. It may qualify for some impairments due to loss of strength, for example, for loss of strength in resisted knee flexion if the biceps tendon is involved. May also involve some weakness in the form of resisted hip abduction if the iliotibial band is involved. So always be thinking about different and alternative impairments that your examinee could possibly qualify for. Okay, so let's talk about the physical examination of these structures. And because there's so many structures involved in the lateral aspect of the knee, our physical examination is going to have to include many or several maneuvers to assess these structures. So to begin, lateral opening, in other words, resistance to varus forces, that's stabilized by the lateral collateral ligament with secondary restraint provided for by the popliteofibular ligament here. Popliteofibular ligament here. And then also is stabilized by both the anterior and the posterior cruciate ligaments. So this may be another example when you detect excessive lateral opening of the knee joint that could suggest a combined injury qualifying the examinee for impairment due to collateral and cruciate ligament damage. Posterolateral rotation forces are stabilized by the popliteofibular ligament primarily, with secondary restraint provided by the lateral collateral ligament and then also the popliteus tendon, which runs right through here. Okay, so let's talk about how to assess these structures. Okay, so to begin, we begin with a simple varus stress test. And like the valgus stress test for the assessment of the medial collateral ligament, we're going to first perform the varus stress test at full extension and then again at 15 degrees of knee joint flexion. So in full extension, if we detect slightly increased lateral opening of the knee joint, that's going to suggest injury to the lateral collateral ligament and to the posterolateral corner structures. Now it's going to be virtually impossible to detect which of the posterolateral corner structures are involved, but it suggests to us that one or more of those structures are involved when we have laxity on full extension. Now, if the lateral opening advances from slight to moderate, or in general more opening, that also is going to suggest injury to additional structures such as the posterior cruciate ligament and or the anterior cruciate ligament, as one or more of those ligaments fail to allow more lateral opening of the knee. So this would be an example of a combined ligament injury involving the collateral and the cruciate ligament. And then at 15 degrees of flexion, increased lateral opening now at 15 degrees of flexion is going to suggest injury to the lateral collateral ligament and then also possibly additional posterolateral corner structures. Okay, so we're going to assess at both full extension and then also at 15 degrees of flexion. So that test is done supine. Then the next test, the passive external rotation of the tibia, rotation of the tibia relative to the femur, that is, this is performed with the patient prone, and we want to perform this maneuver at both 30 degrees of knee flexion and then also again at 90 degrees of knee flexion. So when the knee is at 30 degrees of flexion and we have an increased external rotation that disappears at the 90-degree position, this indicates an isolated posterolateral corner injury, as the posterolateral corner structures are the primary restraints to external rotation when the knee is at approximately 30 degrees of flexion. Now, when we have increased external rotation at both 30 and 90 degrees, what's that going to indicate? Well, it's going to indicate injury to the posterolateral corner, and also suggests combined injury to the posterior cruciate ligament. And any external rotation of greater than 10 degrees side to side comparison is considered significant. So always compare your findings on the involved lower extremity to your findings with the uninvolved lower extremity. And the distinction between these two tests is that when you have increased external rotation at the 90-degree position, that suggests a more serious and severe injury. It suggests a combined injury that would qualify the examinee for the highest permanent impairment rating. Okay? And the literature describes a few other tests as well, none of which seem to be particularly specific to either collateral or cruciate ligament damage. But the literature talks about the external rotation ray curvatum test, the reversed pivot shift test, and probably the most applicable and the most practical is the posterior drawer test with the foot in external rotation. And with the foot in external rotation, you as the examiner would simply apply a posteriorly directed force to the tibia on the femur. And if there is posterolateral rotatory instability, you will detect this on this maneuver. You'll detect this as the tibia subluxes posteriorly relative to the femur. Okay, so that is the lateral collateral ligament. And again, in an isolated lateral collateral ligament injury, which is rare, the AMA guides provide for 3, 7, and 10% whole person impairment. But as we've seen, injury to the lateral collateral ligament generally involves other structures, including one or more of the cruciate ligaments, and so those combined injuries qualify for much higher permanent impairment ratings. So it would be the exceptional case that qualifies for isolated injury, and it would be the more general case, the more numerous cases, the more common cases that qualify for the higher impairment ratings because of the co-occurrence of collateral and cruciate ligament injuries simultaneously. Okay, so always assess your examinee for all the ligamentous structures around the knee and be forever aware and attuned to the possibility of the coexistence of these combined ligamentous injuries. Okay, so let's talk now about the cruciate ligaments. Now that we've discussed the collateral ligaments, let's go on to the cruciate ligaments. Okay, so here's a diagram of the anterior cruciate ligament, and you're looking at the right knee from the anterior aspect. So this would be the medial knee here. This would be the lateral knee here. So the anterior cruciate ligament has its femoral attachment, its proximal attachment, its origin is laterally. It's on the lateral wall of the inner aspect of the lateral femoral condyle. This area is known as the intracondylar notch. So the intracondylar notch is between the condyles. That's what intracondylar means. So here's the lateral femoral condyle. Here's the medial femoral condyle. This is the intracondylar notch here. And the anterior cruciate ligament attaches up here on the lateral aspect of the intracondylar notch. So its origin is lateral. And then it comes and it crosses, and that's what the cruciate ligaments mean. They're crossing ligaments. And it attaches anteromedially here, which is on the anterior part of the tibial plateau near the tibial spine, or I should say the tibial spine. You can see the anterior tibial spine here, and the posterior tibial spine is tucked away back in here. So the anterior cruciate ligament begins laterally and progresses anteriorly to attach anteromedially on the anterior aspect of the tibial plateau. And the anterior cruciate ligament is a fascinating ligament. It has kind of a coiled or a twisted cable type of structure, such that it becomes separated out into an anteromedial band. So here we see some of these anterofibers tucking and coursing and getting rotated and then attaching over here medially. It's the anteromedial band. And then the posterolateral fibers attach over here laterally on the anterolateral aspect of the tibial plateau. And this is a dynamic ligament where the anteromedial band tightens when the knee approaches full flexion, and the posterolateral band tightens as the knee approaches full extension. So the anteromedial band would resist hyperflexion forces, posterolateral band would resist hyperextension forces, and this allows the ligament to function and be active and provide passive restraint throughout the full range of knee joint flexion and extension. And according to some research studies, the anterior cruciate ligament has proprioceptive nerve endings. So it's a dynamic structure that contributes to the neurologic stability and the neurologic stabilization of the knee joint itself. So thus, you can see that injury to the anterior cruciate ligament would result in loss of functional as well as loss of anatomic stability. There would be a loss of anatomic stability and a loss of functional stability through diminished neuromuscular control of the knee. The anterior cruciate ligament is the primary restraint to anterior translation of the tibia here on the femur here. So the ACL here prevents forward movement of this tibia relative to the femur. And of course, the posterior cruciate ligament is going to do the exact opposite. The anterior cruciate ligament is also the primary restraint to knee hyperextension due to the action of the posterolateral band. Now, when the knee is in full extension, the anterior cruciate ligament provides restraint both to varus and valgus angulation. And that's interesting because the anterior cruciate ligament can be injured by both valgus and varus forces, especially when the knee is planted and in full extension. Okay, and so that would likely involve injury, most likely, to the posterolateral band. And then, in addition to resisting anterior translation and varus and valgus forces, the anterior cruciate ligament is a restraint to both internal and external rotation when the knee is at full extension. And in opening today's discussion, we talked about the osseous restraints provided for by the shape of the structures. And because of the flat and planar surfaces of the tibial plateau, we don't have a lot of osseous restraint to rotational forces. So we simply have here the anterior cruciate ligament located centrally, which can resist internal and external rotation forces. But because this ligament is located centrally versus peripherally here, it has a small moment arm and a small point of leverage, such that it's easily overwhelmed by both internal and external rotation forces and is easily injured and damaged by internal and external rotation forces. So when we do our assessments of the anterior cruciate ligament, we want to include internal and external rotation positions in our physical examination testing of this ligament. Okay, on physical examination, the most specific test for anterior cruciate ligament that's described in the literature is the Lachman test. And with the Lachman test, you place the knee in 20 to 30 degrees of flexion, and this femur is stabilized anteriorly. So the doctor's superior hand is placed on the anterior aspect of the distal femur just above the patella and applies a posteriorly directed stabilization to the femur. Then with the opposite hand, the examiner applies an anterior force to the proximal tibia to attempt to translate the tibia anteriorly on the stabilized femur. And the displacement is assessed. So any significant displacement above and beyond normal ligamentous play would qualify for ligamentous laxity. With the pivot shift test, this is an interesting test. In early flexion of the knee, when an internal rotation and valgus stress is applied to the knee, the anterolateral quadrant of the tibia will sublux posteriorly. This subluxation is reduced by the posterior pull of the iliotibial tract as the knee continues its flexion up to 20 and even as high as 40 degrees. So this test is completed all in one maneuver of taking the knee from full extension all the way through to approximately 40 degrees of flexion, at which point you will feel a palpable clunk over the anterolateral quadrant of the tibia as the tibia first subluxes itself and then reduces itself throughout that range of motion. So a palpable clunking qualifies as a positive pivot shift test and is suggestive again of laxity of the anterior cruciate ligament. Now on radiographs, many times with injury to the anterior cruciate ligament, the plain films will show an avulsion fracture of the insertion of the anterior cruciate ligament onto the anterior tibial plateau. Sometimes you will see an avulsion fracture of the anterior and posterior tibial spines. And then also you'll see occasionally a Sagond fracture. And a Sagond fracture is indicative of a varus stress to the knee because it involves a lateral capsular avulsion from the margin of the lateral tibial plateau. So this is in response to a strong varus stress, strong unrestrained varus stress. Okay, so here we have an AP radiograph of the knee, and this appears to be the intracondylar tunnel view. But anyway, here we see a Sagond fracture, which is an avulsion fracture of the margin of the lateral tibial plateau here. So this is in response to a strong varus angulation in this direction that causes failure of the anterior cruciate ligament here, and then continued opening laterally such that there's a avulsion fracture of the capsular attachment over here on the lateral tibial plateau. So in your knee radiographs, we now have at least two findings. One is the Pellegrini Stieta lesion, and the second here is the Sagond fracture. That would be indicative that your examinee has suffered bona fide injury to these ligamentous structures, and that they may indeed qualify for either an isolated permanent impairment rating or a permanent impairment rating due to combined injury to collateral and cruciate ligament injury. Okay? And I have some statistics regarding patients who have suffered injury to the anterior cruciate ligament. And we're talking about grade 3 rupture injury. And this is a study that I was able to find. It's not a new study. It's a 1994 study. But it was published in a respectable journal, the American Journal of Sports Medicine. And they followed 292 patients, each of whom had suffered a ruptured anterior cruciate ligament. And they followed these patients for an average of 5 years. Well, a small percentage, approximately 20%, underwent anterior cruciate ligament reconstruction within the first 3 months, and another 20% requested surgery over the next 5 years. And the reason they requested surgery was because of adverse impact of this condition on their activities of daily living, particularly adverse impact on their ability to return to sporting activities. Well, the remarkable finding from this study is that 62% were able to function satisfactorily without an intact anterior cruciate ligament. And this may come as a surprise to you that more than half of the patients in this study were able to resume their normal sporting and daily living activities without the passive restraint provided for by an intact anterior cruciate ligament. And this is not such a surprise to me because I myself suffered a ruptured anterior cruciate ligament at approximately age 17, more than 40 years ago. And it was never reconstructed. It was simply resected and cleaned out and debrided, and I was left without an anterior cruciate ligament, and I was able to go on and play all types of sporting activities, including ice hockey and downhill skiing and all kinds of sports that involve cutting and twisting and turning and changes of direction. And that was because, and the reason these patients did so well is because the dynamic structures, the muscles that cross the joint, are able to compensate for the passive restraint provided for by the anterior cruciate ligament. So if you think about it, the primary function of the anterior cruciate ligament is to resist anterior translation of the tibia on the femur. And in the absence of an intact anterior cruciate ligament, the role of restraining the tibia is relegated to the hamstring tendons. So the hamstring muscles and hamstring tendons can satisfactorily substitute for examinees who have ruptured and who have not even had a repair of the cruciate ligament. But the AMA guides tells us that in examinees who have had injury to the anterior cruciate ligament and who have persisting laxity and instability and adverse impact on their activities of daily living, they provide for permanent impairment rating due to isolated cruciate ligament injury and also for combined cruciate ligament injury when the injury to the cruciate ligament is combined with an associated injury to one or more of the collateral ligament injuries. So always assess all of the cruciate ligaments and all of the collateral ligaments to provide your examinee with the most accurate permanent impairment rating. Okay? Okay, and finally, let's finish up with some discussion of now the posterior cruciate ligament injuries. Okay, with the posterior cruciate ligament has its origin on the medial femoral condyle. Okay, remember the anterior cruciate ligament had its attachment on the lateral femoral condyle. This is now on the medial femoral condyle, with its attachment is in the shape of a semicircle, and it inserts laterally, so it goes from medial to lateral, into a depression between the posterior aspect of the two tibial spines. I'm sorry, between the two tibial plateaus, about 1 centimeter below the articular surface. And I have a good diagram to show you that gives you a good spatial representation of the insertion points of the anterior and the posterior cruciate ligaments. And like the anterior cruciate ligament, the posterior cruciate ligament is functionally divided into two bundles, the anterolateral and the posteromedial bundles. Now, the anterior cruciate ligament had an anteromedial bundle and a posterolateral bundle. Here, the posterior cruciate ligament has the opposite configuration. And the anterolateral bundle is the primary restraint to the posterior drawer maneuver at 40 to 120 degrees of knee flexion. And that's the one that we're going to be primarily assessing with our drawer maneuvers. And then the posteromedial bundle is the primary restraint to posterior drawer at full knee flexion. So this is the bundle of fibers that is most likely injured or damaged when the examinee undergoes a knee hyperflexion injury. So like the anterior cruciate ligament, the posterior cruciate ligament functions throughout the full range of motion to provide functional restraint to the knee throughout the extreme of knee flexion and knee extension. Okay, so here we have the posterior cruciate ligament here, and we see that it has its origin on the posterior aspect of the medial femoral condyle. Here's the medial femoral condyle, and its insertion point takes on the shape of a semicircle here. So it attaches medially, traverses slightly laterally to attach at a point midway between the two tibial plateaus posteriorly. So here's a tibial plateau here, here's a tibial plateau here, and you can see that the attachment point is approximately at the midpoint between the two tibial plateaus. So if we look at the superior aspect of the tibia with the femur and the patella removed, we get this diagram here. So this is medial here, this is lateral here, this is posterior here, and this is anterior here. We see that the attachment of the posterior cruciate ligament here in between the two tibial plateaus is on the posterior aspect of the tibia, much more posteriorly directed than is anteriorly directed the attachment of the anterior cruciate ligament, which is right here. So this is the attachment of the anterior cruciate ligament. This is the attachment of the posterior cruciate ligament here. So you can see that these attachment points are almost linearly aligned. So this creates a difficult situation in terms of leverage and moment axis of rotation for the tibia bone for these structures to resist the tibia bone in either internal or external rotation, and explains why these ligaments are quite easily torn in either of internal or external rotation is because of the small moment arm and the small axis of rotation to resist high rotational forces. So these injuries are frequently involved in rotational injuries. Okay, now let's talk about the physical examination of the posterior cruciate ligament. Okay, so we know that the posterior cruciate ligament provides primary restraint to posterior translation of the tibia on the femur. And so most of our physical examination maneuvers are going to involve some aspect of attempted posterior translation of the tibia on the femur. Also, the posterior cruciate ligament serves as a secondary stabilizer to varus angulation of the knee, so that it contributes to the lateral ligamentous complex to resist varus angulation. And then also when the knee is in 90 degrees of flexion, the posterior cruciate ligament helps to restrain external tibial rotatory displacement as a secondary stabilizer. So most posterior cruciate ligament injuries that we're going to encounter in the workers' compensation setting are going to involve circumstances where the examinee falls onto a flexed knee. and comes down and applies a force directly to the tibial tuberosity to drive the tibia posteriorly on the femur. Secondarily, we might see injuries that involved forced hyperflexion, such as an examinee coming straight down onto the ground on his fully flexed knees and the weight of the body crumpling the knees into hyperflexion. And then also the posterior cruciate ligament provides some secondary restraint to forced hyperextension of the knee, although by the time the posterior cruciate ligament becomes injured with a forced hyperextension injury, the anterior cruciate ligament has already taken the bulk or the brunt of the injury. And then finally, varus and valgus forces are resisted to some extent by the posterior cruciate ligament. However, by the time the posterior cruciate ligament becomes involved from an excessive varus or valgus force, the associated collateral ligament will have already failed. So this again is yet another example of where these injuries occur in tandem and comprise the compound or complex component or variety of ligamentous injury, in which case the examinee is going to qualify for the highest impairment rating that's provided for by the AMA guides. With the posterior cruciate ligament on physical exam, we're going to rely on 3 basic testing procedures, and we're going to get some help from one of our prior test procedures involving the anterior cruciate ligament. So recall, with the anterior cruciate ligament, we went through the Lachman test, and with the Lachman test, we assess anterior translation of the tibia on the femur. In cases where we deem that the translation of the tibia on the femur is excessive with the Lachman test, that is one indication of laxity of the anterior cruciate ligament. Well, it's important to keep in mind that with a posterior cruciate ligament deficient knee, the Lachman test will show increased anterior to posterior translation, but unlike the injury to the anterior cruciate ligament, with the posterior cruciate ligament injury, we're going to see a firm anterior endpoint with the Lachman test as the intact anterior cruciate ligament comes into play to restrain anterior translation. And this is can be deceptive because the increased translation that we're seeing in this Lachman testing with a posterior cruciate ligament deficient knee is due to posterior subluxation of the tibia on the femur due to lack of posterior cruciate ligament, which then becomes reduced into its normal position on forced anterior translation by use of the Lachman test. So excessive anterior translation on the Lachman test can be deceptive and be attuned to the presence or absence of a firm anterior endpoint. A firm anterior endpoint could deceive you into thinking that you're dealing with a anterior cruciate ligament injury when in fact you're dealing with a posterior cruciate ligament injury. So in addition to the Lachman test, we want to employ the posterior sag, and I have a depiction of that to show you in just a moment. With the posterior sag test, the examinee is supine, the hip and knee are in 90 degrees of flexion, and the legs are supported by the examiner, who has his forearm underneath the calcaneae of the examinee. And in this position, gravity applies a posterior force to the tibia, and with an injury to the posterior cruciate ligament, we're going to see posterior displacement of the tibia relative to the femur, and we're going to see the tibia shrink away from the patella as the tibia displaces posteriorly. So that's the posterior sag test. The posterior drawer test, we're going to perform this at 90 degrees of flexion. So the examinee will be supine with both feet on the table, and with a posterior directed force to the tibial tuberosity, If we have a posterior translation of the tibia of 0 to 5 millimeters, that qualifies as a grade 1 or mild laxity. A posterior translation of the tibia of 5 to 10 millimeters is a grade 2 laxity, and greater than 10 millimeters of translation with no firm endpoint generally is suggestive of a rupture or an absent or a deficient posterior cruciate ligament. Finally, we have the quadriceps active test, and this test uses the dynamic contraction of the quadricep muscles to assess the stability of the tibia on the femur. So with the examinee supine, the feet are flat and resting on the table, and the examinee produces a voluntary contraction of the quadriceps by applying a knee extension force. Now the feet are restrained on the table, so there's no actual extension of the tibia on the femur, in which case in a posterior cruciate ligament deficient knee, the anterior aspect of the tibia will translate in relation to the femur. So when the feet are stabilized and the extension is prevented at the distal aspect of the tibia, the proximal aspect of the tibia has no choice but to sublux anteriorly, and this is a physical examination finding for laxity of the posterior cruciate ligament. And here we have a depiction of the posterior sag test. The hips and knees are positioned in 90 degrees of flexion. The examiner would be out here supporting the examinee's legs by placing the forearm underneath the calcaneae here. And then in this position, simply the effect and force of gravity applies a posteriorly directed force to the unstabilized end of the tibia. See, this end of the tibia is stabilized here. This is the unstabilized end of the tibia, which will show a sag sign. And that sag sign is depicted in the sagging of the skin and the displacement of the tibia posteriorly from the underneath surface of the patella. So this close-up view here depicts what would ordinarily be the contour of the skin with an intact posterior cruciate ligament, but because the tibia displaces posteriorly due to lack of restraint by the posterior cruciate ligament here, the skin follows the translation of the tibia and creates a sag sign through this region here. So that's a very simple physical examination maneuver that will be positive in examinees who have bona fide laxity of the posterior cruciate ligament.
Okay, so doctors, I hope this helps you. It's important, and one of the main principles of today's discussion is that these ligamentous injuries rarely occur in isolation. More commonly, and generally, they occur in tandem or in combination or in what the literature refers to as complex injuries. So in every single examinee, you must assess each of the four ligaments circumferentially around the knee, because it's more generally the rule than the exception that you're going to find multiple ligamentous instabilities around the knee, and this will qualify the examinee for the higher permanent impairment ratings provided for by the AMA guides, which they generally actually will qualify for. Now, you will pick up these impairments in your physical examination of your examinee if you have specific procedures in your physical examination template to assess for these instabilities. Many times, and this is a general principle, many times in our clinical practice, we do our physical examination maneuvers and procedures differently than we do in our medical legal permanent impairment evaluation practice. In our permanent impairment evaluation, we are examining the examinee for the presence or the absence of impairments. And many times this is different from what we do in our clinical practice. In our clinical practice, we typically examine our patient. In our clinical practice, we have patients, not examinees, but we examine our patients for diagnosis, for diagnoses. And once we can identify the diagnosis or diagnoses, then we can direct the treatment plan to address those particular diagnoses. Well, by the time we see injured workers in the permanent impairment evaluation, they've already been diagnosed by multiple practitioners and they've already received extensive and copious medical treatment. So the purpose of the permanent impairment evaluation is not to identify diagnoses or to render opinions on necessary medical treatment, but rather is to identify the presence or the absence of impairments. They either have those impairments, in which case they qualify for a permanent impairment rating, or they don't have those impairments, in which case they don't qualify for a permanent impairment rating. Well, in Chapter 17, the lower extremity chapter, one of the impairments that can result from lower extremity injuries, especially to the knee, is ligamentous laxities. So your physical examination of every single lower extremity case must assess for the presence or absence of ligamentous laxities. So I'm suggesting that you make necessary modifications to your physical examination template for the lower extremity and for lower extremity cases to include a thorough assessment of ligamentous stability of not only the knee but also the other articulations of the lower extremity. So doctors, I hope this helps you. In our next session, we're going to jump forward and get off of the lower extremity, and we're going to conclude this program with a very detailed discussion of instability syndromes of the spine and what the AMA guys have to say about permanent impairment ratings due to loss of motion segment integrity of the spine. So I'm sure you're going to find that to be a very useful and a very fascinating discussion. So I look forward to being with you on our very next session. For now, this is Dr. Perry Carpenter wishing you best of success in your career as a qualified medical evaluator.